Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about hypertension. When I left off last week, I was in the process of telling you guys how to begin the first treatment for hypertension, the first step, the first level at which we begin to actually prescribe medications. But before I do so, I want to make a correction. I believe when I left off last week, I was talking about as well about B12 deficiency. The adult per individual has 5,000 microgram of B12, not milligram, microgram. And we lose about 0.05 microgram per day through the stool and then to sloughing of the skin, etc. And we need about 2.5 milligram of B12 in our diet in order to remain B12 sufficient if we don't have a problem that can prevent that from occurring. I just wanted to clarify that. It's 5,000 microgram. Okay, so hypertension. Last week, I began the treatment of hypertension in someone who had blood pressure 140/90. I decided to start a water pill. And the water pill that I began after, of course, all the evaluation, the blood test, the chemistry profile, the EKG, echocardiogram, chest X-ray, do all this stuff, assuming all these things normal. If they're not, if they're abnormal, then there are processes that we go through to evaluate it, including an echocardiogram and possible cardiac stress test, etc., 24-hour Holter, that kind of stuff. It is different situation for different patients. Some folks have nothing but elevated blood pressure very early in the game, and we start treating them with a thiazide water pill. It's got to be a thiazide water pill because the loop diuretics work too quickly. They work within half hour after you take them, and they stop working about 4 hours later, thereabout. The thiazide diuretic, however, can last up to 8 hours after you take them. And the part of the kidney that the thiazide diuretic works on that causes you to lose salt is different than the loop diuretic. The loop diuretic goes via the loop of Henle, we call it. The thiazide diuretic goes via the distal convoluted loop tubule, the convoluted tubule, whereby the sodium absorption is blocked right there, and so doing the salt comes out in the urine, and the water follows, and the blood pressure comes out. So that's the first step. Everybody who has a functioning kidney, no matter who they are, what they think of themselves, must get a thiazide water pill first. It is only if the thiazide water pill, and I'm going to give you the list, I have a list of diuretics here, is not sufficient, then you go to add a second or a third or a fourth medication, depending on the circumstances, assuming all blood tests and everything else, of course, normal, etc. Even if they are abnormal, you still have to find out the extent of the abnormality, and you have to, of course, treat accordingly. I've copied these from this big book here, the chapter number 1, African American Women Health. And let me see the list of diuretics. Okay, what I have here is the hydrochlorothiazide. We got chlorothalidone, diazide, moduretic, aldactone, lozol, M.A.C.P, M.A.C.P and Lasix, of course, those are loop diuretics, etc. So I'm going to stop there after the aldactone. And then you're going to add a second or third medication, depending on the level of medication of the blood pressure. Let's say somebody's blood pressure is like 160/100. That's stage 3 already. That's significantly high blood pressure. A water pill is not going to be sufficient. Then you have to choose a second medication. The question is, which is the second medication? This is where the ethnic differences steps in. If the patient is a Caucasian individual, it's perfectly fine to add an ACE inhibitor, such as Zestrel, Acuprol, Capoten, Vasotex, Altace. Any one of these will do. Depending on the size of the individual, you choose the dose of the different medication. Why? Because the Caucasian individual has ample amount of renin that is produced by the kidney to block, to help lower the blood pressure. All Caucasian individual has normal level of renin. All non-Caucasian individual, regardless of the skin color or what the person, he or she thinks of ourselves for social reason, political, whatever, has low renin. You cannot be a non-Caucasian person and don't have low renin unless your kidney is failing. When the kidney is failing, that's a different situation. The renin is always going to be high. If you have renovascular hypertension, the renin is always going to be high. You have to understand, 97% of non-Caucasian individuals have low renin. The condition during which where the renin is high, then the ACE is contraindicated. You can't give somebody an ACE whose kidney function is insufficient. If you do so, it's going to make the kidney function worse. It's going to raise the blood urea nitrogen. It's going to raise the BUN, and of course, it might also raise the potassium. That's bad medicine. You cannot do that. So therefore, then, it is very important that you pay close attention to the ethnicity of the individual you are treating for hypertension. Not to discriminate against anyone. That is completely disgusting, revolting. No one should discriminate against anybody. However, the physiology is a classic example where the difference in the physiology of different ethnic groups. If you are a surgeon, you're practicing surgical medicine, 99.9% of the time you will find the organs in the same place regardless of the individual ethnicity. That's not the same in general medicine. It's not the same in pediatrics. It's not the same in OBGYN, etc. Because the physiology is different. The same thing applied in certain instances to women as well. Certain medication don't work as well in women as compared to men. You have got to know these things and take them into consideration. Because if you don't take them into consideration, you are not able to provide high quality, effective care for this individual. Okay? Let me repeat that. You can't be a non-Caucasian individual, no matter what you look like, without having low sodium renin. I mean low renin, right? Low renin in your blood. Therefore, then, what is the ACE is going to do? The ACE works by block the effect of renin in the renin-angiotensin pathway. By blocking it, and so doing, you lower the blood pressure. That's how these medications work. They're very good medication, but they're not good for everybody. Okay? Now, you say, but then, Val, what are you going to do for, let's say, a Negro individual like me who has, if I were to have hypertension or somebody like me were to have hypertension? Well, you could go right ahead and give them the water pill, and then there are other medication that can be used. We talk about the ACE, so let's put the ACE away. And an individual nowadays, now that we have a restriction dealing with the ABs are fantastic. They're really, truly fantastic because the AB work via the entire renin-angiotensin receptor blockers all the way through. They go from beginning to end, all the way to aldosterone. No other medication does that. So therefore, this series of medication, unfortunately, we are now facing a situation where there's a shortage or an absence, for that matter, of the generic ABs. All the generic ABs have been put on hold by the FDA because of some toxicity they say that occurred in a factory in China as well as in India, where those generic medications were being made, according to the government, that toxic material can ultimately look to cause cancer. However, keep in mind that, to the best of my knowledge, if you could afford it, the brand name medications such as Cosa is still available. And to the best of my knowledge, that was not part of the contamination effect. I'm not 100% sure, but I haven't heard anything about Cosa being contaminated. And Cosa is an AB. Okay? Now, what the ABs will do, the AB will block the entire pathway all the way to aldosterone. Why is that important? Well, it's important because aldosterone is the very last step in that pathway, but aldosterone is a substance that the kidney produces that causes you to retain salt. Wherever salt goes, water follows. If you retain salt, you're going to retain fluid with it, and that's going to expand the intravascular system, which then can cause your pressure to go up. So the idea then, what makes this medication so fantastic for to treat blood pressure, because you could use them in all ethnic groups. In addition to that, they are fantastic medication to treat when someone has congestive heart failure. The ACE are fantastic for that as well, but there is a restriction. If you are a person who is not Caucasian, what's the point of using the ACE if you have CHF? Because you could use an ARB. That will do both things. It will help the congestive heart failure. It will also help to treat the hypertension. So this is how important these things are. And there are several ARBs on there. You have COSA, Avapro, Diovan, Asion, Atacon, Benicar, Vicardis. As far as I know, these things are still okay because then those were not listed as the things that are contaminated according to the government, to the best of my knowledge. So that's one group of medication. So this particular individual, I would then add blood pressure. Remember, 160 over 100. I would add 100 milligram of COSA together with the water pill, and then see the patient a couple of weeks later. We check the blood pressure, and if the blood pressure comes back to normal, then that's the regimen you will keep that particular patient on. Okay, now there's another group of medication that are just as fantastic, but they work via a different mechanism. We call them the calcium channel blocker. They are multi-ethnic. You could use them in every ethnic group, irregardless. Okay, let's say for that same patient, I decided, for whatever reason, that I did not want to use an ARB, but I wanted to use a calcium channel blocker. What are calcium channel blockers? Well, vessels have muscle in them, smooth muscle in particular, and the first lining there. And you can't contract. I cannot do this with my hand. I cannot contract my hand without the help of calcium. Calcium plays a major role in allowing a vessel to contract. So those medications where when the vessel is contracted, the pressure goes up. If you have angina, it can cause angina. So what happened is that once it was first discovered that when you give these calcium channel blockers years ago when they were just made, they were basically made to treat angina pectoris. That's right. To relax those muscles, open the vessel to allow blood and oxygen to go through. It turns out that it was discovered a side effect of the calcium channel blockers were dropping the blood pressure. And because of that, ever since then, they're being used strictly to treat blood pressure, except in cases where there are certain arrhythmias that we could use verapamil, we could use cardizem, which are fantastic medication to treat arrhythmias as well. Other than that, they're being used across all the way through to treat hypertension. How does it work? Well, once, remember, calcium channel blocker, this medication block the ability of calcium to contract the muscle. By blocking the action of calcium, the muscle relaxes, allow blood to go through, the pressure comes down. How about that? And they are good medications, okay? I'm giving you the list that are most commonly used. You have verapamil, you have cardizem, procardia, adalat, caduet. Those are the most commonly used calcium channel blockers. Okay, and there are many more, I'm sure. So now you understand how the calcium channel. It's very important that those medications are available because different people have different symptoms to this medication. They develop side effects from them, so you have to switch from one to another to try to control the blood pressure. Okay, so now let's say the blood pressure in the individual is like 180 over 150. That's really way up there. Now we are talking about stage 4 hypertension. So what you're going to do? Okay, again, you're going to give a water pill, thiazide water pill. You're also going to give the patient, you have choices. You could use an AB, depending on the level of the renal function. If the renal function is abnormal, the BUN is high, the creatinine is high, you stay away from an AB. You stay away from ACE, because that was one of the things that can make that situation worse. So here comes your calcium channel blocker. You could go right back, go right to your verapamil or your cardizem. And on top of that, since the pressure is so high, those two medications may not be enough. But in an acute setting, you must bring the pressure down. Very easy. What you do is that you give the patient nitro paste. That's right. You're not giving the nitro paste to treat angina, because the side effect of the nitro paste is the lowering of the blood pressure. And you could use 1/4 inch, 1/2 inch, 1 inch, and it depends on the circumstances. And the patient can wipe out the nitro paste whenever he or she thinks there's a problem. Headache is one of the most common side effects. So you're going to add that. Because acutely, you give the patient a nitro paste either in the emergency room. I know people like to use labetalol, but when you use labetalol, you got to be very careful. And I'll talk about beta blocker in a little bit. That the patient EKG is okay, because if the patient has heart block, you're going to give labetalol, you're going to make the heart block worse. You don't need that. The heart block is conditioned whereby the electrical system of the heart is affected. So you got to be it's a good medication, but you got to be very careful. Okay, so what do? You use a nitro paste, because these other medications take time to kick in, but the nitro paste works immediately. And you're right there, you have control of it. As the pressure comes down, you could wipe it off. This is in the acute setting. On top of that, if you don't want to use the nitro paste, you're watching the patient, you could use alpha blocker. And so you have a water pill, thiazide water pill, you have a calcium channel blocker or an AB, and you also have access to alpha blocker, such as clonidine. The clonidine works quick and fast. Okay, 0.3 milligram of clonidine stat will bring the pressure down pretty quickly. So you have 3 medications on board now. You have clonidine, you have calcium channel blocker or an AB, and you have your water pill. So you're in business. You're just watching the pressure comes down very carefully and be confident that it's going to come down. Okay, that's how. And if the patient, of course, has to be admitted, most of the time they are in this setting, then you put the patient on telemetry, and you have complete access and plenty of time to slowly bring that pressure down. All right? If the patient, that pressure that high, you want to make sure you get a CT of the head to make sure no bleeding has occurred. And later on, get yourself an MRI, MRA to properly evaluate the brain, because this patient is been hypertensive, God knows for how long. He or she may have a whole host of things that may have happened that he or she didn't even know, such as silent strokes, severe microvascular disease of the brain, a whole host of other stuff that will have happened. So you must always, you do the CAT scan first, because it's very easy to get. Remembering that CAT scan will not diagnose an acute stroke for you unless it's an acute bleeding stroke. It will, however, diagnose stroke that has occurred in the past, but not ischemic stroke is diagnosed acutely by doing MRI, MRA, and CAT scan rule out bleeding. That's very important. Ruling the fact that there's no bleeding is crucial as well. It's free your hand to evaluate, to do different things for the patient that you ordinarily wouldn't do. Okay, I mean, you certainly wouldn't give the patient aspirin. Is part of your reason you want to give the patient aspirin. Certainly wouldn't do so unless you make sure there's no bleeding taking place. And always remember, before you give anybody aspirin in an emergency setting, or for that matter, ordering aspirin for someone, you must make sure they don't have any underlying bleeding abnormality. That's right. Okay. 77 million people across the world have a condition called von Willebrand disease, where aspirin is contraindicated. And this country is about maybe 3.2, 3.5 million people have von Willebrand disease. They don't even know they have it. You just can't take aspirin and give it to people. Aspirin is contraindicated when you have von Willebrand disease, because von Willebrand disease is a qualitative platelet abnormality. And when you take aspirin causes man-made qualitative a medical problem. That's why you give the aspirin, to prevent the platelet from aggregating that can cause you to have a stroke or a heart attack, blah, 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 blah. But you just don't take aspirin unless you first get evaluated by your physician to make sure that you don't have underlying bleeding problem. On top of that, it gets worse, because significant percentage of individuals develop hemophilia as an adult spontaneously. You can't make this up. Spontaneously, it's nothing. They know anything about it. I have several patients in my office that I was getting ready to send to the OR, and I do my PTT, and suddenly the PTT comes back abnormal, and I evaluate it. I have one gentleman who was going to have shoulder surgery. He wound up with hemophilia B. He knew nothing about that, and he was getting ready to go to the operating room. Okay. I subsequently sent him there, but I prepared him in a way that he could have that surgery. And I have ways that I can do that. I won't bore you with that. Of course, we send people who have bleeding problems to the OR all the time, but we know about it and prepare them for that. All right. So let me read to you the rest of the alpha blockers that are available: Hytran, Cadura, Aldomet, Adrenaline. All these are alpha blockers. They can be used in different settings. Now, I brought with me a list of the of medications, the beta blockers. I bought them as well. Beta blockers are fantastic medication. They really are, because we use them to treat arrhythmias. We use them to treat congestive heart failures, but you have to remember, there is no reason, never, and a few reasons I'll tell you about them, to ever give somebody a beta blocker as monotherapy to treat essential hypertension. You cannot take a piece of chalk and go to the blackboard and show me, Val, this is the mechanism. Nonsense. It doesn't work. And unfortunately, it is being done, sadly. You cannot, let me repeat that. The circumstances in which you could use a beta blocker, such as Enderal, Labetalol, Coreg, Tenormin, Topol X, these are fantastic medications, but you have to know when to use them. If somebody has pheochromocytoma, which is a condition whereby a tumor develops in the adrenal gland, that tumor secretes adrenaline. Well, the best medication to block the effect of the adrenaline is to give a beta blocker. That's a different situation. Okay. Let's say, for the sake of argument, I have somebody who's working under tremendous stress all day long, or he or she is hypertensive, and I'm treating them with my usual combination of medication. However, that person, during the course of the day, under intense pressure, the pressure go up and down, unstable. You could put a little dose of beta blocker during the day for that patient that will prevent the pressure from jumping up and down, okay? But that's not the main medication. The main medications are on board, but you squeeze a little bit of that beta blocker in between to prevent the jumping up and down of the pressure when he or she is under stress, okay? That you could do, but you cannot justify, and I'm being very sincere. No one could ever justify giving somebody a beta blocker as monotherapy for, that is one medication, mono means one medication to treat essential hypertension. That is completely, totally false, wrong, cannot be done. If it is being done, that's unfortunate. I'm serious. I know I sound like I'm pontificating, but I'm not. I'm telling you it should not be done. Because to do that, you don't understand the mechanism. If you do, you know it doesn't work. Okay? But there's a fantastic medication. If somebody has essential hypertension, which they frequently do, and they also have congestive heart failure, of course you're going to put a beta blocker on board. The beta blocker then allows you to do incredible things. This is how incredible beta blockers are. You have beta blockers that work for 24 hours. Why is that important that we have beta blockers like Topol XL, meaning long-acting? Very important, because all of us, all human beings that goes to bed at night to sleep, by the time 3 o'clock comes in, all of us secrete tremendous amount of adrenaline naturally. That's a natural phenomenon to get the body ready for the work that's coming next day. That's right. All of us go to bed by 3 o'clock in the morning. We secrete tremendous amount of adrenaline naturally. However, if you're secreting adrenaline, which we all do, and you have an underlying heart problem, like ischemic heart disease, you are at risk of developing a heart attack. That is why, my friend, most heart attack, can't make this up, most heart attack occurs Monday morning, from Sunday night into Monday morning, because people are so anxious of the job they're going to have to deal with, the stress they have to deal with Monday on the job. So the most heart attack, if you didn't know it, now you know most heart attack occurs between Sunday night into Monday morning, okay? Because of the secretion of adrenaline, because the heart cannot withstand the stress of the adrenaline. The heart is overworking, overpumping, and you already have underlying ischemia, bingo, you have a heart attack. That is why these beta blockers that are long-acting were created, because of that reason. So you cover the patient throughout the 24 hours so that when the adrenaline starts secreting at 3 o'clock in the morning, you have enough beta blocker on board to cover the effect of the adrenaline protecting the heart. You understand that? Okay. I'm going to stop here. I'm going to continue this discussion next week. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.